Hi everyone. I'm Dr. Sapna, one of the mentors at StudyMEDIC, and today I'm going to be taking you over a short snippet on endocrinology. We call this our RRR series, and we do this every year before the exam so that the people who are preparing for it get a quick review and recap of all that they have studied. This is our another attempt at helping you all preparing and going into the exam very confidently. The quote for the day and also for life is that the only place where success comes before work is in a dictionary. So there is no success without hard work, and all of you have put in really a lot of hard work, as we can see in our groups. I'm sure that success is going to be yours. Your dedication, your effort, and your perseverance is going to finally pay off very soon. So just don't lose hope, don't quit, and keep working hard and stay with us, and we'll help you and we'll be there with you. So what we aim at doing today is to cover important topics, important questions from the most recent exams that have been covered, and also you will get a quick revision and recap of a little bit of endocrinology. Now endocrinology mainly is about feedback mechanisms and the actions of the various hormones. So if you know about that, I don't think endocrinology will pose a major problem for you in the exam. So stay calm and think about the feedback mechanisms, and I'm sure you should be able to max the exam, at least as far as endocrinology goes. So let's begin with our first question. Now this question is a favorite amongst the exams for a lot of reasons. One, because the thyroid is a very important gland, and thyroid hormone questions overall are very important. Okay, so the question here is about a 35-year-old individual who presents to the GP for an annual health checkup, and during the consultation they inquire about thyroid function tests, as they recently read that the importance of thyroid hormones is very important in metabolism. Now they are curious about balance between thyroxine T4 and triiodothyronine, which is T3, in the bloodstream. So they've just given you a story and then they've put forth a very straightforward question that's very RCOG like. Okay, so what is the approximate normal T4 to T3 ratio? Is it 7:1, 10:1, 14:1, 20:1, or 1:1? So although I'm sure that all of you know the answer, let's just quickly go over and check what the answer is. Now coming to the answer is that it is 14:1. Now, which means that T4 is produced in significantly higher amounts by the thyroid gland compared to T3. But we also know that T3 is the one that is more biologically active. So in the periphery, or in mainly the liver and the kidney, the T4 is converted to T3 by the enzyme 5-deiodinase. Okay, and this ratio is very important, because if there is an imbalance in this ratio, which indicates thyroid dysfunction, maybe because of hypothyroidism, in which there is T4 is increased and decreased T3, or the other way around, there's decreased T4 and elevated T3, which means that the biologically active hormone is more, which happens in hyperthyroidism. So this ratio and its maintenance is clinically very important. Okay, so our next question is, how does progesterone act on estrogen receptors? So we need to know, of course, the interaction between these two. Then we will be able to, kind of exclude the incorrect options. So let's go through the options first. A, it enhances the number of estrogen receptors. Now think whether this can be true or false. So when the progesterone comes in, the estrogen action is actually decreasing. So from common knowledge, that means that it will not enhance the number of estrogen receptors. That seems to be the incorrect statement. It inhibits the action of estrogen receptors. it reduces the number of estrogen receptors, it activates estrogen receptors, or it prevents estrogen synthesis. Now, I would definitely rule out enhances the number of estrogen receptors. That's option A. And option D, which activates estrogen receptors. Now, let's see between B, C, and E. So, does it prevent estrogen synthesis? Well, it's not actually because of that. It's because the feedback mechanism of the entire hormonal this thing. So it is not inhibiting estrogen synthesis. And whether it is inhibiting the action of estrogen receptors? No. It is reducing the number of estrogen receptors. I think that should be our answer. And let's see. So, well, here we are. The answer is it reduces the number of estrogen receptors. Now, during the proliferative phase, we are all aware that the estrogen receptors are more prevalent in the stromal and the myometrial epithelial cells. However, the progesterone's suppressive action causes a rapid decline in the concentration of the estrogen receptors during the ovulatory phase, and then progesterone regulates the development and function of the endometrium by interfering with the replenishment of these estrogen receptors, which results in reduced sensitivity of the endometrium to estrogen, and therefore progesterone takes over and we get into our second half of the cycle into the secretory phase. So this is another exam favorite. Which adrenal gland zone secretes the androgens? So basically we need to know a little bit about the adrenal anatomy. So we know that it is divided into the adrenal medulla, which is in the middle, and the adrenal cortex. Now the adrenal cortex also has 3 layers. From out to in, it is glomerulosa, fasciculata, and reticularis, GFR. Now our question is asking which adrenal gland zone secretes androgen, whether it is the glomerulosa, fasciculata, reticularis, the medulla, which is in the middle, or the capsule. Now let's see what the answer is. There you go. The answer is zona reticularis. So how we usually remember is out to in is GFR, glomerulosa, fasciculata, reticularis, and how we remember what each zone produces is salt, sugar, sex. Okay, so salt as in the mineralocorticoids or the aldosterone, then the glucocorticoids or the cortisol, and sex hormones like the androgens. So this is how I usually remember. Now let's solve this one. What type of receptors does progesterone act on? Well, these kind of questions you really either know the answer or you don't know. And since there are no negative markings, we definitely recommend that you make a wild guess, or if you know it, even better. So let's see what the options are. G protein coupled receptors, ionotropic receptors, enzyme linked receptors, or nuclear transcription receptors, or voltage gated channels. Now let's see what the answer will be. So the answer to this one is nuclear transcription receptors. Now let's read a little bit about it. Progesterone receptors are nuclear receptors. That means the receptors are present in the nucleus and which act as transcription factors to regulate gene expression. Now there are 2 forms of the progesterone receptors, A and B. Progesterone's actions on the uterine tissues are determined by relative levels and transcriptional activities of progesterone receptor A and progesterone receptor B. Now the B is the predominant form of the receptor during pregnancy, and this produces uterine relaxation. Okay, and progesterone A is a repressor of progesterone B function. So as we can correlate, during labor, at the onset of labor, it is progesterone A receptors which are acting more than the progesterone B receptors, because that time the uterus is meant to contract. Another one of the most favorite recalls, and it has come in the recent exams also, when is the growth hormone released maximally? So the growth hormone actually comes in waves. Okay, so there are times when it is at its peak and then there are times when it is very low. So when is it released maximally? The options given are during light sleep, during deep sleep, during physical activity, after meals, and during prolonged fasting. So what do you think the answer could be? Well, here we are. The answer is during deep sleep. Now, it does increase after exercise also, but the peak, as we can see, is more following during deep sleep. So, the correct answer is during deep sleep. Okay. This is a frequently asked question. Another, if you know answer. Okay. So, I mean, you need to really know about it. Otherwise, it's going to be a wild guess. How many carbon atoms are present in estrogen and progesterone and glucocorticoids and mineralocorticoids? So they've given you option A, B, C, D, and E, in which they've mentioned the various number of carbon atoms that can be possible in various hormones. Now let's just go to the answer. So our correct answer over here is option A. Now estrogen, it is derived from androstenedione. Androstenedione here has 19 carbon atoms and it loses one carbon atom during aromatization and forms estrogen. So estrogen has 18 carbon atoms. Progesterone has 21. Okay, this is derived from pregnenolone, which also has 21 carbon atoms. So this progesterone is 21. Glucocorticoids is again 21. Okay, it is derived from pregnenolone again, as you remember in the hormone sequence that we learn in the adrenals. Okay, so the pregnenolone has 21 and glucocorticoids or cortisol, they will also have 21. Now coming down to mineralocorticoids, that is also from the same precursor, that is pregnenolone, which also has 21. So this also has 21. So apart from estrogen, which has 18, the rest of the three have 21. So there you are with your answer, option A. So there will be some questions in the exam which you feel will be so easy, okay, but then they want you to pass. So they will give you some easy questions as well. So which of the following is the primary role of prolactin in lactation? Does it stimulate oxytocin release? Does it promote milk ejection from alveoli? Does it suppress milk production? It stimulates milk synthesis in the mammary glands, or it regulates breast involution after weaning. Now, always remember that there can be more than one seemingly correct options, but you need to choose the single best answer. Now, let's move on and see what the answer is. So here we have option D, which stimulates milk synthesis in the mammary glands. Now, we should know that prolactin and oxytocin, they are interdependent hormones, and one will help the other to perform all its functions. Prolactin helps maintain oxytocin concentrations, and when the baby suckles, it stimulates the secretion of both the hormones. Now, breast development during pregnancy, prolactin will help in the development of the breast tissue for breastfeeding. It also helps in milk production. Okay, so suppressing milk production is option C is incorrect. Letdown reflex. Prolactin works with oxytocin to trigger the letdown reflex, which allows the milk to be released from the breast. Okay, so it does promote the milk ejection from the alveoli. However, it is not that the role of prolactin as a primary one. Okay, so the option D, which stimulates milk synthesis in mammary glands, is our correct option. All right, so here we have another one which is based on a clinical scenario. A 52-year-old woman presents with fatigue, constipation, and bone pain. Her serum calcium is elevated and parathormone levels are also high. Which of the following best describes the mechanism of hypercalcemia in primary hyperparathyroidism? Now we need to know what the role of parathormone is, what it does in the calcium metabolism. So let's go through the options. A. Increased calcium excretion in the urine. B. Increased calcium absorption from the gut. Decreased osteoclastic activity. What will that do? Reduced renal calcium reabsorption or impaired activation of vitamin D. Now parathormone, basically the role of parathormone is to increase the levels of calcium in the body when the calcium levels fall down. So now let's go and see what the answer will be. So parathormone, it increases the intestinal calcium reabsorption indirectly by stimulating the activation of vitamin D in the kidneys. It also increases calcium reabsorption in the renal tubules, and it mobilizes calcium from bone via osteoclastic activation. So it does not decrease osteoclasts, it increases osteoclast so that the bones will release the calcium and the calcium goes to the blood. So the option B, increased calcium absorption from the gut through vitamin D activation, is our correct answer. Which of the following is the primary androgen secreted by the adrenal cortex? Is it testosterone, dihydrotestosterone, dihydroepiandrosterone, androstenedione, or estradiol? Now let's see what the answer will be. So first, before we should know that which zone of the adrenal cortex is releasing this. Can you tell me? GFR, salt, sugar, sex. So it is the R, which is the reticularis, which is releasing it. So DHEA is the primary androgen which is produced in the adrenal cortex, primarily in the zona reticularis. It can be converted into more potent androgens like testosterone in the peripheral tissues. So now there's another question that is often asked, in what order is the testosterone more potent? So the potency of the testosterone hormone is often asked, and that is an important thing that all of you should know. Also in the female body, which testosterone is most active or in more dominant form, that is another question that you should know the answer to. What is the primary cause of Cushing syndrome, whether it's the pituitary adenoma, adrenal adenoma, adrenal carcinoma, familial Cushing syndrome, or iatrogenic Cushing's syndrome? Now let's proceed to the answer before I finally tell you what I am wanting to teach. So Cushing syndrome is actually a broader term that describes the clinical condition resulting from prolonged exposure to excess cortisol, regardless of what the source is. Now the primary cause or the most common cause of Cushing syndrome is actually iatrogenic, that is exogenous corticosteroid use, example in long-term high-dose glucocorticoid medication like prednisone. Endogenous causes are when Cushing syndrome is due to internal factors, and the primary causes will be adrenal adenomas, which are tumors of the adrenal gland that produce excess cortisol, or ectopic ACTH production by certain tumors like the small cell lung cancer, which can produce ACTH on their own and which will stimulate the adrenal glands to produce excess cortisol. And another question that they often ask is, what is the primary cause of Cushing's disease? So one is Cushing syndrome, the other is Cushing's disease. Now the options that they usually give are pituitary adenoma, adrenal adenoma, adrenal carcinoma, familial Cushing syndrome, or it could be iatrogenic. Now in this you don't really need to think twice, okay, because what we need to know first is that Cushing's disease is actually a part of the Cushing syndrome spectrum, okay, but Cushing's disease is what is primarily caused due to a neurological cause, okay. So here the answer is pituitary adenoma, and let's go and check what the answer is again. So as we had already told you, the answer is pituitary adenoma. Now we need to know that Cushing's disease is primarily caused by a pituitary adenoma that secretes excess adrenocorticotropic hormone. So Cushing's disease is basically something which is caused from the neurological causes or the pituitary adenoma, okay. So you don't really need to get confused between Cushing's disease and Cushing syndrome. Cushing's disease is also Cushing syndrome, but the origin is only in the brain. So here I've put this question intentionally, okay. A 40-year-old man presents with central obesity, thin extremities and purple striae on the abdomen. What is the diagnosis? It's Cushing's syndrome. Now his 24-hour urinary cortisol is elevated, which points us towards the diagnosis that we were having in our mind. What is the most common cause of endogenous Cushing's syndrome? Okay, so since they've mentioned endogenous, we're not even going to think about iatrogenic. Okay, the options are whether it's between adrenal adenoma and pituitary adenoma. Okay, the rest of them are not the most common causes. Okay, so let's now go and see which is the most common cause of Cushing's syndrome. So here we are. Between pituitary adenoma and adrenal adenoma, Cushing's syndrome is most commonly caused by pituitary adenoma, since that is more common than the adrenal adenomas. Okay, so here our answer is going to be pituitary adenoma. We do not think about ectopic ACTH secretion from the small cell carcinoma of the lung, okay, because that is a very small proportion of cases. It is not exogenous glucocorticoid use because our question is asking about endogenous Cushing syndrome. Adrenal hyperplasia is caused due to the pituitary adenoma, but that is a secondary thing that is happening. Okay, so the cause is pituitary adenoma. So here's another seemingly straightforward question. Which of the following is the primary action of oxytocin during labor? Does it relax the uterine smooth muscles, inhibits prostaglandin synthesis, it stimulates uterine contractions, or it suppresses fetal cortisol production, or prevents cervical dilatation? I'm sure you all know the answer. If you don't, then you can even use the exclusion method, and from your clinical knowledge, you will get to the answer. And let's now see what the answer is. So, the primary action of oxytocin during labor is stimulation of uterine contractions. Oxytocin, it binds to the receptors in the myometrium and it triggers the contraction during labor. It also, of course, has a role in the milk ejection during lactation. Now, this is a very interesting question. A 26-year-old woman presents with irregular periods, hirsutism and acne. Pelvic ultrasound shows polycystic ovaries and her testosterone levels are elevated. So she has clinical and biochemical hyperandrogenism. Also, ultrasound is showing polycystic ovaries. Which of the following best explains the source of androgen excess in PCOS? Whether it is A, excess adrenal androgens which are being secreted, B, increased peripheral conversion of the estrogen to androgens, C, increased ovarian theca cell androgen production, reduced sex hormone binding globulin production, or increased pituitary LH secretion. Let's see what the answer is. Well, here we are. The answer to this is increased ovarian theca cell androgen production. Now, what happens in PCOS? We all know that there is high LH and hyperinsulinemia also. Now, the excess LH, it will stimulate the ovarian theca cells because the LH acts on the theca cells, and therefore there is increased androgen production. Now, there is reduced sex hormone binding globulin also. It also will contribute to the higher free androgen levels in the blood. Now, insulin, what it can do, it can have either a direct action on the theca cells, or it can actually stimulate the pituitary to produce more LH hormone, which will give rise to this excess androgen production. So the correct answer over here is increased ovarian theca cell androgen production due to the increased LH and the hyperinsulinemia. So now here is another clinical scenario. A 45-year-old woman, she presents with complaints of fatigue, weight gain and irregular periods over the past year. So, alright. She has a history of fractures in minor falls. We are forming a diagnosis in our mind. On examination, she has a BMI of 32 and the DEXA scan shows reduced bone mineral density. Our diagnosis seems to be right. Now the question is that the blood test has shown low estrogen levels and they want to know what is the role of estrogen in her bone health. So again, this is from clinical knowledge, what happens in the menopausal stage when the bones become osteoporotic and the estrogen levels is low. But let's see what the options are and what the answer could be. Whether it enhances calcium absorption from the gut, do you think that happens? The calcium levels do fall. Estrogen reduces bone resorption from osteoclasts. So whether that is possible, osteoclast activity is reduced premenopausally. That's why the bones are strong. Maybe, yes. Estrogen increases osteoclast formation. No. Estrogen stimulates bone resorption. No. Estrogen inhibits vitamin D synthesis. Now let's go and see what the right answer is. So here we are. The answer is estrogen reduces bone resorption by osteoclasts. So now estrogen is actually going to suppress the osteoclast activity and bone resorption. so the bone density is maintained. And this protective effect is obviously in the postmenopausal stage when the lady is estrogen deficient. Okay, it leads to development of osteoporosis. So our answer will be that estrogen reduces bone resorption by osteoclasts. So here is another clinical scenario. Now you have a 22-year-old professional runner and she presents with secondary amenorrhea. She has been amenorrheic for 8 months and reports strict dieting and intense training schedules. So you need to have these key points in mind and try and find a diagnosis in your mind, and then let's see what the question wants to know. Her BMI is 18.5 and her hormonal studies reveal low estrogen and progesterone. Which of the following is the most likely mechanism of her amenorrhea? A. Hypothalamic suppression due to excessive stress. B. Ovarian resistance to gonadotropins. C. Pituitary adenoma, which is suppressing the gonadotropin secretion. D. Is it due to uterine scarring? E. Polycystic ovarian syndrome. Now, we need to, of course, we can rule out also, but let's see what the answer is directly. So here we have a professional runner and she has presented to us with secondary amenorrhea, and we know that she has got intense regime and she is on strict diet control also, and the hormones are low estrogen and progesterone. So we can easily rule out that she is not suffering from polycystic ovarian syndrome because of the low estrogen levels. There's no history of instrumentation, so uterine scarring doesn't seem to be a likely probable answer. Pituitary adenoma, again, there are no symptoms or signs which are suggestive of that. And hypothalamic suppression due to excessive stress. Now we know that because of the reduced caloric intake and the energy that she's spending on her exercise, the hypothalamus is actually energy deficient and it causes hypothalamic amenorrhea, hypothalamic functional amenorrhea. So our answer is hypothalamic suppression due to excessive stress. Here we have another thyroid question. A 60-year-old woman presents with fatigue, cold intolerance and weight gain. The blood tests show elevated TSH and low T4. What is the role of TSH in regulating thyroid hormone synthesis? Now, whether it stimulates T3 and T4 release from thyroglobulin, whether it inhibits iodine uptake by the thyroid gland, it enhances conversion of T4 to T3 in the peripheral tissues, it suppresses T4 synthesis in the thyroid, it decreases thyroglobulin production. Now think about what the answer is, and now we'll move to the right answer. So I think this was a simple, straightforward question. The TSH role is to stimulate T3 and T4 release from thyroglobulin. Okay, so this didn't really need. This was like a no-brainer. It was a straightforward question. Now here is one of the most confusing but most important and very interesting diagnosis. So let's just quickly go through the question. A 55-year-old woman presents with bone pain, fatigue and kidney stones. Her lab results show elevated calcium, low phosphate and high parathyroid hormone. What is the most likely diagnosis? Whether it's hypercalcemia of malignancy, secondary hyperparathyroidism, primary hyperparathyroidism, hypoparathyroidism and osteoporosis. Now again, we need to know what the parathormone does and then reach the answer. Let's see what the answer is. Now here clearly the elevated parathormone suggests that the parathyroid glands are the source of the cause of the hypercalcemia. Now elevated calcium, low phosphate and high parathormone, they clearly point towards a diagnosis of primary hyperparathyroidism. So symptoms such as bone pain, fatigue and kidney stones are also consistent with our diagnosis, and our answer will be C, primary hyperparathyroidism. Now, hypercalcemia of malignancy would also show maybe, of course, hypercalcemia, but the parathormone level here would be low because this is not dependent on parathormone. It is parathormone independent. And secondary hyperparathyroidism, it also usually has low or normal calcium levels with high parathormone. So here with elevated calcium and high parathormone,
diagnosis of
Okay, so
primary
here we have a minute
hyperthyroidism
which
is
will
ongoing.
actually help us clear our doubts between the primary, secondary, and tertiary hyperparathyroidism. So, a 40-year-old woman, she has a long history of chronic kidney disease and is found to have persistently elevated parathormone despite normal calcium levels. Imaging reveals hyperplasia of all the 4 parathyroid glands, and what is the most likely diagnosis, whether it is primary, secondary, tertiary hyperparathyroidism, whether it's pseudo hyperparathyroidism or hypoparathyroidism. Let's see what the answer is. So this question actually has been put so that you know that there are different entities. So in the first question we dealt with primary hyperparathyroidism, in which there was elevated parathormone, elevated calcium and low phosphate levels. Now there is a secondary hyperparathyroidism also, in which the condition is secondary to a condition like, for example, chronic kidney disease, and because of that the parathormone is stimulated and it kind of produces more parathormone and tries to keep the calcium levels normalized. Now what happens when there is a long standing chronic kidney disease which has caused this hyperparathyroidism? The parathyroid glands, they become autonomously active. Okay, so despite a renal transplant and despite correction of the calcium levels, the parathormone, they just autonomously get active and they get into hypersecretion mode, and this causes what we call as tertiary hyperparathyroidism. So a primary hyperparathyroidism is because of inherent parathyroid problem. Secondary is induced from a secondary cause like a chronic kidney disease. Despite having treated that chronic kidney disease by even a renal transplant, when the parathormone stays high, that condition is known as tertiary hyperparathyroidism. So just let's read the answer. Tertiary hyperparathyroidism, it occurs when the parathyroid glands have become autonomously hyperactive after prolonged stimulation. So I hope this is clear now, and in the exam you all will not get confused. Now there is another entity called pseudo hyperparathyroidism, or it is also pseudo hypoparathyroidism, because what happens in it is the clinical scenario is of hypoparathyroidism, but the parathormone is elevated. This is actually a genetic cause, okay, and this is because the receptors are resistant to the parathormone, and any amount of parathormone, the receptors are not going to get activated, and so the scenario becomes pseudo. Okay, yeah. So I hope this was helpful for all of you. So I hope this was useful for all of you. These were just a very few questions, but I hope the concepts got a little clear. And as you're approaching your exams, we'll be sending you more such RRR videos by our various mentors. And we hope that these small snippets actually will go a long way in helping you preparing for your exam really well, so that you go into your exam really confidently and come back happy and contented with your performance and of your hard work that you've been really putting in. So I'll be seeing you soon with another session on RRR, and all the best from all of us. All the best.